Good afternoon, everybody. Welcome to our session on climate and health and as well as pandemics and the social determinants of health. We've been given a rather broad brief, but I think we're mostly going to focus on the issue of climate and how that interacts with those other issues. My name is Lynn Goldman, and I am Dean of the Milken Institute School of Public Health at the George Washington University, and I'm your panel moderator. And I'm very pleased that we have with us today a number of wonderful experts who will be speaking as part of this panel. Dr. Victor Zhao, who is the president of the National Academy of Medicine, and Zulfi Bhutta, who is on the faculty of the Hospital for Sick Children at Aga Khan University, right? Sorry.
And the Milken School of Public
Health. And the Milken School of Public Health. We do have a goal that everybody in here will eventually be on my faculty. Ann Kurth, who is president of the New York Academy of Medicine and has been a dean of nursing also at Yale University. And John Balbus, also on the School of Public Health faculty, but most importantly, he directs the WHS Office of Climate Change and Health Equity.
Can I make an application?
Yes, and I will enroll you on the spot. You are now enlisted. Yes, Dr. Paz as well. So I'm going to give a very, very brief introduction to this issue. And I think that, we've been challenged from the earlier session to speak clearly, about these issues that involve science and politics. So I'm going to try to exemplify that. To start at the beginning of all of this, if you go back about nearly 2 million years, humans began to use fire. Why? To keep ourselves warm and to cook. And fire is actually a very simple chemical reaction, where you take an organic molecule and you convert that to what? Water and carbon dioxide, and maybe some other things that are kind of pollutants that are dangerous to health as well. So we've done that for millions of years, we humans have, and then we've gotten more sophisticated. We have changed from using sticks and branches and wood to do this, to using peat, to using charcoal, getting coal out of the ground, making coke out of coal, getting fossil fuels out of the ground, burning natural gas, but and even something that we call biofuels. But at the end of the day, we're using that chemical reaction that makes water and carbon dioxide. And why is this a problem? Somewhere around 1900, the carbon dioxide levels on our planet began going out of control, rising and rising. The planet could no longer handle the amount of carbon dioxide that people were producing. Why was that? I think we all know. That's about the time when human populations had reached somewhere in the ballpark of 1.5 billion people on the planet. We passed a dubious milestone last year of 8 billion people on the planet. So the more people on the planet doing this chemistry, the more carbon dioxide is produced, and we have seen, as a result, really exponential increases in the temperature of the Earth. The IPCC has called this the climate time bomb. It's unfortunately a time bomb that's not ticking. It's already going off, I would say. I think, to be clear, this is not a ticking time bomb. This is a time bomb that has already started detonating. I think that is important. And the health consequences are already very clear with the changes in the climate. We have more extreme weather, we have heat, we have changes in the distribution of vectors, we have food insecurity, we have people suffering because of climate extremes and other extremes, dislocation, trauma, the mental health impacts of all of that, much less just the concern. But I think there are many people who are being very directly impacted. So the IPCC has given a number of recommendations. They've tried to simplify. They've said, reduce fossil fuel use renewable energy, have a circular economy, quit wasting things. You could capture the carbon and store it, although we don't yet have a convincing method for doing that. And we can green our cities. But I'm going to say something simpler. We have to stop doing this chemical reaction of producing CO2 in order to make our energy. And it doesn't matter how we're doing it. If we're using coal, gas, biofuels, it could be renewables, it doesn't matter. We're making too much carbon dioxide and we need to bring some of it back out. And so I think that's an opportunity for me now to turn to our panel. And I think that the members of our panel are each in positions where they are uniquely capable of doing actions to reduce this threat to health. And I'm going to ask each one of you in turn, starting with the person to my immediate left, Dr. Zhao, what are you and your organization doing? What is the most important thing that you're doing to address this problem?
Thank you, Lynn. And it's great to be on this panel. I see lots of friends and members of my academy, so I'm very proud. I think that you framed it really well, but I think you ought to also, I thought that's what you can do about the human suffering side, right? The lives lost, the health impact, and many others. So, it's really difficult to get good numbers, but if you look at everything included, including the issue of diet and others, you're talking about 20 million deaths a year related to climate events. And so that's huge if you think about this. I mean, COVID-19 over 3 years may have killed about 10 million, but when you think about that event, it's amazing. But you also think about the issues of human sufferings, economy, displacement, poverty, immigration, migrants. So many issues that's related. So I think Jonathan Pass showed me one slide. I used to think about, most people think about climate change like a polar bear on a slab of ice that's shrinking. But in fact, the real faces are faces of human beings, right? It's immediately happening to us in terms of suffering, illness, and I don't have to go through all the things you know about, extreme weather, you name it, but also in terms of equity. Because when you look at who suffers most, and I'm sure Sophie is going to talk about this, that actually is low-income communities, low-income countries, where they do the least emission, but the greatest impact, because their livelihood is dependent on the natural resources, such as agriculture, forestry, fishery, you name it. So I just want to make sure first that I set the stage to say it's a public health crisis and it's an equity crisis. Now, once you accept that, you all know that we need to act. There's an urgency, right? It's not like tomorrow. My grandchildren, my great-grandchildren, is today. My friends, my colleagues, people around the world who are suffering. And so the main message I want to give, Lynn, is the urgency of this issue. It's a true crisis. So I will just quickly mention what we're doing because of that. Our members, many of them here, have certainly recognized this issue as the community of biomedical community to say, we need to take responsibility. First of all, when it's a public health crisis, obviously we are the most trusted individual professions to be making sure we deliver the message publicly. So we need to communicate. We also need to educate ourselves and our workforce, doctors, nurses, frontline, to be aware of this issue, so that not only they're communicating, but also they're practicing. So that leads me to the second issue. Second issue is looking at what are we doing? Well, the medical community, will do a lot of good to help people, illness, prevention, but we're also contributing to the carbon emission. At the United States, it's 8.5% of total carbon emission, the health sector, and globally it's about 2.54%. It's huge. So therefore, if we don't practice, first do no harm, but also I strongly believe that through the actions of decarbonization, we can actually improve healthcare. Just think about more prevention, more remote monitoring, you name it. We can go into some of that issue. Third is the recognition that health and climate are not a single isolated entity. It interacts with many different sectors: agriculture, transportation, energy, food, water, and most of the economic models of the sectors are consumption, emission. what do we need to do to reduce emission, reduce consumption, versus what are we doing in human health? So policies can be made without consideration what it means to human health. And so our argument is that you need to bring all the sectors together to look at this issue. This is called Roadmap, which Judy Roden and Andy Haynes are leading. Research innovation, we can talk a lot about what's needed, not only in high-income countries, but low-income countries, mitigation, adaptation, innovation, you name it. And finally, of course, to me, the equity issue is so important. So we're making a major effort called the Climate Community Network to extend to, in the United States, doing a heat map of where the communities are with the highest impact, and also looking at lived experience, bring them in, but now also working globally as well. And importantly, engaging messengers and narratives, particularly related to the younger people, to collect data, to do photo voice, and to be able to that message to start looking at how we can change the community. So thank you very much. That's our grand challenge.
Sophie.
Everything that you've said, Victor, resonates very strongly with what I would have said if I was speaking on this de novo. So let me tell you what a card-carrying neonatologist like me, what does it take for someone like me to get interested in climate change and health? And I can tell you my own journey around this over the last few years at the Aga Khan, where as a university group, when we began to look at this, we were struck by the levels of disparities and injustices that we saw in front of us, not just in terms of the burden estimates, that they were grossly underestimated in terms of the contribution of climate change, particularly the combination of heat-related events and disasters, to the health of women, children, the most vulnerable, particularly in rural populations, but also the reality that so little was being done at this in a tangible manner. Now, all the discussions, whether it's COP27 or before that, or the Paris Accords, was around the kind of things that Victor was talking about: mitigation strategies, what can you do to reduce emissions, and very little on strengthening and helping people who are in need today. So my own area of work on the two areas that I've mentioned, maternal child health and nutrition, just imagine climate change, if you don't address this, will increase global hunger by 20% and translate that into worsening malnutrition by 2050. The impacts on the most vulnerable women and children, if you just take perinatal mortality as an example, all the available evidence, even though it's limited, indicates that you're looking at impacts which are close to the range of 10 to 15% excess in stillbirths, increase in prematurity in terms of incident rates, and other adverse outcomes. In Pakistan alone, in the work that we've done at subnational level, it looks as if climate change by itself, heat plus the reduction in soil moisture, is a significant contributor to increasing stunting rates. Mm-hmm. So these are the realities out there which are not in the public domain. Mm-hmm. But the more important thing is not just the doom and gloom scenario. I think what is really important out there, and that's where I'm so pleased that the Academy is taking tangible action, which needs to be emulated by others, is to look at what can be done in terms of resilience and adaptation today. What can we do to empower communities, the very communities who are not going to be impacted by any green climate fund or any loss and damage fund, but they need interventions today in terms of mitigating and addressing things that are happening in front of them. And there are tangible solutions as we've begun to explore this, and there may be time to discuss low-cost solutions that can be implemented in both urban and rural settings that can help alleviate some of the suffering and problems as we talk today, while the world gets its act together on reducing emissions and now and achieving the 1.5 degree centigrade target that we all aspire to.
Thank you. Anne Kerr.
Well, thank you. Each of you are here because you are concerned about improving health around the world. And I want to take us back to the 20-teens. Let's go back to 2019, could we? When we were making advances in many arenas for certain populations and health systems impact. And then one new novel pathogen. We know there's 350 at least emerging and re-emerging pathogens to come. Look at the devastation just from COVID, combined with the climate crisis and its accelerating effects. And that is, of course, a health equity crisis. And then in the structure of social determinants of health. So you came to this session, I think, because you saw the title and recognized these are syndemics that we are dealing with right now in front of us. When we think about health, it's about people. And my focus and interest that I want to touch on today is around health, the health workforce issues. So again, coming back to the 2010s, 2019, we already were $15 to $19 million short, 15 to 19 million health professionals short around the world, right? And now there were some progress that was being made. We had the global health workforce building efforts. We had that happening around the world as well as at country levels. For example, Rwanda did some very innovative health system strengthening work across its clinicians. And here we are now back again to at least a $15 to $19 million shortfall, particularly amongst nurses and midwives, who are 59% of all health workforces around the world, and most of whom are female. So again, as you think about gender issues and syndemics, people were burned out, people were maldistributed, people were not given resources prior to COVID. These trends have only accelerated. So as we think about the work of dealing with the climate crisis, certainly mitigation is a must. But as my colleagues have noted, we have to also think about health system and public health system adaptation. And that has to happen now. It's quite remarkable when you look at the literature on when climate crisis is being discussed, the health sector is often left out, really until recently, until COP27. Adaptation monies, which is about getting systems not only able to get through a crisis, but to bounce forward from them and learn from them, is a very small percentage of adaptation funding. So in 2022, the World Health Organization has talked about a compact for healthcare workers, that we have to provide safe conditions, that we need lifelong learning and support. And we really do have to address the resilience of our healthcare workers around the world. There were mental health stresses before COVID. It's really only worse now. How do we actually recruit across the cadres of health workers, ensure that people get state-of-the-art education, and how can we use technology tools to assist with that at scale? How do we then ensure that people will stay in healthcare and public health and community work? Because we're losing large numbers. In the United States alone, with all its resources, half the US public health workforce left between 2019 and 2021. So this is a global crisis. We need to address healthcare as a team, and we need to be able to ensure that we are both educating to the climate crisis needs of communities, working with communities, but ensuring that there are still healthcare buildings standing at the end of the day.
Thank you. Thank you very much, Anne. Ellen.
Thanks very much. And let me just express my pleasure in being here, the honor of being on this panel with distinguished colleagues, and thank you all for being here as well. I'm going to take the liberty of being the bookend because Lynn and Victor opened up with the same points that I think we're all trying to make. And I'm going to try to say something and speak really, really clearly. And I'm going to say this as somebody who has identified as an environmental health professional for nearly 30 years. But for the healthcare and public health sector, there will be no progress on climate change until climate change stops being thought of as an environmental health issue. I'm just going to say that again. There will be no progress for the healthcare, and that includes the global health sector and the public health sector, until such time as climate change stops being thought of as an environmental health issue. I see some nodding heads. I think you understand why this is. It's because when we make something an environmental health issue, it means it's the purview of the environmental health people, and it lets everybody else off the hook. We've been working on this for 30 years. Dr. Patz and I have been working on this for 30 years. Many in this room have been working on this for a long, long time. Our progress has been inadequate. The question of what we do is urgent. So long as it's an environmental health issue, we won't make progress. And the flip side is that, we've been to many COPs, and the World Health Organization at all the COPs says we just want to make sure that health is at the table.
Mm-mm,
It's not about being at the table, my friends.
mm-mm.
Health will not become a climate change issue. And I'm living this in a very tangible way right now. Health will not become a climate change issue until climate change becomes a mainstream health issue. Let me give you just one small example of what this looks like. And it's a good news example. 2 weeks ago,
I have some thoughts.
Center for Medicare Medicaid Services issued a waiver. It was a waiver that allows healthcare system grids, health system, oh gosh, I've forgotten the acronym, I didn't write it down. But basically, it changes the emergency preparedness rule under which all healthcare facilities in the United States operate
Right.
to be allowed to use solar and other renewable energy power as their primary backup.
Mhm.
This was the implementation of an existing National Fire Protection Agency rule from 2021, but it took a little bit of doing to get a blanket permanent waiver operated. It sounds like it's a resilience thing. It sounds like it's about backup power, but this opens the door now for the health sector to provide their electrical power through renewable sources. If you couldn't use it for your backup, it wasn't going to make sense to do it otherwise. Decarbonization, I think, is the pathway to get the health sector to take this seriously. It's going to be a huge challenge in the post-pandemic world. We know this. I mean, there's nothing to say, but Victor gave the statistics. The US healthcare sector emits as much carbon dioxide and greenhouse gases as a moderate-sized country. Health sector globally less intense than the United States, but still a pretty decent-sized
Oh, wow.
country. If the world health sector were emitting a really toxic chemical into our environment, we'd want to do something to stop that, right? We would all band together to stop that. And by the way, we did that, didn't we? We did that with mercury.
Mhm.
Mercury is a really bad toxin. Carbon dioxide is an existential threat. So why isn't there a complete consensus among us to eliminate that, I ask? Our office is created to catalyze this transition. We are focusing both on the Department of Health and Human Services, and also on all of the sectors that are essential to protect the health of those at greatest risk. There's a lot of things that we're doing. Right now, we're doing what we can do with no congressional appropriation and very, very limited staffing. But we are working to provide, so we've partnered with the White House. We're creating our own community of practice through a pledge. We just reopened the pledge. We'll be announcing new members that have joined in the last week on Earth Day. We will be releasing a set of resources to allow the health sector to better understand easily how they get finance, because someone's going to have to pay for this. The Inflation Reduction Act is transformational. It is relevant to the health sector. We're going to make sure the health sector understands that. We've worked with the EPA to modify the EPA portfolio manager to customize it for the health sector so that half the hospitals in the country now using that can embellish their tracking of their own resources. That's a start of the kind of things that we're doing. I just want to close by saying that the United States, so there was a transformational moment, in my opinion, in the world of the UNFCCC, and that was Glasgow, when under UK leadership, we established the COP26 health program, which has since become something called the Alliance for Transformational Action on Climate and Health, or attached. There are now 63 countries around the world whose health ministries, the mainstream health ministries, not a doctor at a hospital, but the mainstream health ministries have committed to decarbonization and health system resilience. We are hoping that COP28 will be a big step forward. In my opinion, it will only be a big step forward if there are a lot of steps this year in settings like this, where the whole global health community says, this is our issue. We are working on decarbonization. One last thing really quickly. One of the reasons it's really hard is that if you look at a pie chart of that 8.5% of the US or 4.5% of the globe, it's got a ton of wedges. There aren't 3 wedges that we eat and then we're all done. There are many, the biggest wedges are those related to on-site emissions, those related to the energy use or scope 1 and 2 of healthcare facilities. There's a pretty big wedge for embedded greenhouse gases in the supply chains in pharmaceuticals and medical supplies, food, transportation, and then there's another 15 wedges. So we're going to have to contemplate those pieces of pie, look at them carefully, put them in our mouths, chew, digest, swallow, and move to the next piece of pie. It's going to be a process. Some of the pieces are real easy. Some of the pieces are going to be hard to swallow, but we all have to start eating that pie. With that, I'll hand it back.
Thank you, John. So, John, you're reminding me, last year, a number of us and who are deans or leaders of public health schools and programs put together a white paper on behalf of our organization about teaching and doing research and advocacy and working with communities, that all the things that our schools do when it comes to climate and health. And we realized immediately that, as you said, this is no longer an environmental health issue per se, that these are activities that have to involve those who are experts in social and behavioral health, biostatisticians and data scientists, epidemiologists, global health experts. Everybody in health needs to be engaged. At one time it seemed like it's just another kind of emission of a chemical, but that's not what it actually has turned out to be, given the impacts that we're seeing globally on health and the need to center our efforts in health and medicine on this issue, which leads me back to Victor. So Victor, you mentioned at the beginning that as part of this huge effort, actually, that the National Academy of Medicine is doing, and I really have to commend you for your leadership in making that happen, Victor. This has sprung forth just over the last couple of years, and it truly is a very significant effort that I think is going to be very impactful globally. But I'd like you to say a little bit more about, the Action Collaborative. I think a lot of people in the room probably don't even know what that is. What is an Action Collaborative, and why start with the decarbonization of the health sector? I think a lot of us realize that it was hard to get other people to stop smoking when doctors kept smoking. So, I mean, that's kind of an obvious connection, but maybe you could tell us a little bit more about that.
Well, first I should say I have a lot of help. John's one of them. His boss, Admiral Levine, co-chairs this with me. We have Sir Andrew Whitty, part of a co-chair. We have supply chain, George Barrett, former Cardinals co-chair. So we have really a true public-private partnership. So I mentioned we have 5 different programs. This is one of our signature programs. And really, we did with a lot of help. First, thank you, John. Thank you, John Patz and others, to helping us think through what we need to do. So as John Balber said, look, there are different types of emissions, or emissions from what is called 15 different wedges, if you will. And so we need to bring together all the players who are responsible for 15 different wedges. First, of course, is the healthcare delivery. You can imagine that, if you look at what we do in terms of waste, just go to the operating room and look at how much disposable and mask and PPE and you name it that's in there. And of course, the high HUVAC and energy that's needed to, support the work that we do, high technology, you name it. But also anesthesia, gas, I can go a long list of things. The starting point, of course, with care delivery would be that we as healthcare providers need to be aware of what we're doing, and that, in fact, as I said, do no harm, but do good by looking at our practices and begin to change our practice. So that's a really important issue. But in a private-public partnership, we bring in the supply chain. A huge 70, 80% come from supply chain manufacturing, pharma, device, you name it, transportation. And so they also have joined us. So in this collaborative, we have CEOs from health systems, CEOs from supply chain, Medtronic, GSK, AstraZeneca, and others, as well as educators like WAMC, Davis Gordon, ACGM, nurses, all involved with looking at how we can change education, practice, and also, of course, supply chain. But I think importantly is a group that's co-chaired by Don Berwick, Liz Fowler, and John Perlin. And John Perlin, as you know, is the head of Joint Commission. Liz Fowler is the head of CMMI, and of course, Don Berwick. And they're looking at how to actually create policies that's supportive, incentives that enable, and also measurement for us to go forward. So this truly is a public-private partnership with 4 different work streams, each one working on their piece to move forward together. And I want to thank, in fact, John Balbus and WHS to be such a great partner in working along with us.
Thank you for that. I want to turn to another issue that came up in a couple of your presentations, and one that has certainly been of great concern to me from the standpoint of public health, and that is the inequity of the impacts on health due to climate. That, again, it's not just an environmental problem, but this is like an environmental justice problem, in that the communities that are suffering the most probably produce the least CO2 and other pollutants that are actually causing climate change. So they're not benefiting economically from those activities, even while paying the cost in terms of human lives. And I think, as Kofi said very well, it's not just loss of life. It's children whose growth is stunted. Maybe in 40 or 50 years, they'll die earlier than they would have, right? We're not going to see that immediately. And it's going to be hard to do attribution, but we know that that is risky. But I think, particularly Kofi and John, to talk about a little bit to us about how you see that in the context of LMICs, but also even within the United States itself.
So I'll try and address this from an LMIC perspective, Lynn. So one of the most impactful papers that I read on a similar topic some 20 plus years ago was a paper by Jeff Sachs called The Geography of Poverty.
Yeah.
And this was before climate change became, the flavor of the month. And if you read that paper again today, it tells you exactly what he was talking about, and how, as time things have emerged, this inequity between where the impact is felt of changes in climate, particularly heat, and where its impact is going to influence within those geographies also the poorest of the poor. So just look at the reality of where we have seen the impact of extreme heat events in South Asia over the last few years. So people who have suffered the most, both in terms of mortality and morbidity, are those who live in informal settlements and urban slums, where they really have no opportunity of either putting mechanisms in place to address this, or the housing that can be climate friendly, or those living in rural populations who are affected not only by extreme heat, but also by the consequences such as the almost biblical floods that we saw last year. Yep. But here's a statistic from the Pakistan floods. 33 million people were affected within a short span of about 2 months or so. Of the 1,700 lives that were lost, 600 were children. 1/3 of all deaths were children. Over 600,000 pregnant women were impacted in a short period of time. So the people who pay the price are disproportionately the poorest of the poor. So it's like the neglected non-communicable diseases that cluster amongst the poorest billion of the world. The impact of climate change is really seen on those poor. And that's why there is a climate justice issue then. If you look at where the global funds are going right now in terms of redressing this, and let's take the funding that's currently available via OECD for so-called climate change impact, over 90% goes to disaster mitigation. And some then goes to reconstruction. And on the adaptation side, it's less than around 4%. It's around 4.1% that goes to disaster preparedness, resilience development. So we need to be putting our resources as a global community. And I would also extend to say, we also need to put those resources within countries from the allocation to target the poorest of the poor. So this whole issue of making sure that the light shines on areas which are darkest at this point in time, where there is minimal awareness of both the impact, burden, and consequences. This is a priority across the world for academia, for public health professionals, and governments.
And John, do you want to?
Thanks. And just to bring this, into a more of a US perspective, which I think resonates very plainly. Let me just start by saying that the intersection of environmental justice and climate change vulnerability has been put in a completely new perspective by the COVID pandemic, and the parallels and the need to bring the thinking about climate resilience for the future into the present recovery from the pandemic is paramount. And it's all the same thing. Social and racial discrimination over centuries in the United States has resulted in groups of historically and currently traumatized and deprived people. And one of the clearest academic examples of this is all the work that's just been done in the last 5 years on the practice of redlining, which was the practice of depriving people of color, recent immigrants, people with low English proficiency, of financial benefits to allow them to live wherever they want. They ended up living in zones that and stuck there because of the limited finance. And the linkage between the practice of redlining and just about any health disparity in this country persists now 100 years later, whether that's low birth weight, asthma, diabetes, rates of obesity, rates of poor self-determined mental stress and mental health. And so this is one of those examples where our thinking about social justice, climate justice has to be completely hand in hand, finger in glove with our thinking about health equity, post-COVID recovery, and the social determinants of health. And the comment about environmental health is really pertinent to social determinants of health. There are, however you count them, 6 or 7 social categories of social determinants of health. And environment, natural and built environment is always one of them. And if you look at any categorization, data collection, or implementation of action around the social determinants of health, the environmental health side is systematically excluded because that's what environmental health people do. It's not what health people do.
Right.
So we have to change this. One example where these things come together in our office is the issue of plastics. And I'll just say that our office has, as of a year ago, an Office of Environmental Justice housed within it, and we work very closely together. Plastics is where the petrochemical and the fossil fuel industry has gone to increase the need and maintain the need for the extraction of petroleum. The production of plastics is growing rapidly. It is an incredibly greenhouse gas intensive activity. There's just a wonderful report from our colleague Phil Landrigan that just came out about this. So this is a huge environmental justice issue because many places in the United States where the petrochemical plants are located that produce the plastics are emitting toxic substances in the community. The most notorious of these is Cancer Alley in Louisiana, which, oh, by the way, just also happens to be the place where some of the poorest people in the world are bearing a devastating brunt of Category 4 and 5 hurricane after Category 4 and 5 hurricane. So these things are all one in the same issue, and the solutions have to come at this fundamental upstream level of social determinants of health, wedded with the whole health equity movement in the United States and globally. Our office is doing, I'm not going to spend a lot of time talking about what our office is doing, but we're doing many different things, again, within our means. A lot of it has to do with raising awareness of these connections and creating integrated data sets to be able to allow folks to act and target the relief and the finances to those communities that are suffering the most. One example of this is we've worked with the low-income home energy assistance program to bring in health experience data to target the LIHEAP funds for cooling to the areas where the greatest burden of heat-related diseases. There is a whole movement going on within Health and Human Service. We call it the Department of Health and Human Services, but we don't think about what that means. It means that there's $1.4 trillion going to health, but there's also hundreds of billions of dollars going to human services. And we don't often think about those things hand in glove, but they have to be hand in glove when we start talking about improving the social determinants of health, the socially determined health needs. I'll just stop there and we can talk more
Thank
during the
you.
Q&A.
But thank you, John. And I do think that a lot of that, and I know there's other discussions we could be having, but I do want to turn to Anne for comment. You know, when you talk about the lack of awareness about things like, you know, that there's a connection between production of plastics, production of greenhouse gases. I mean, I think we also saw in the last month 2 major disasters in low-income, small communities having to do with plastics. One being the train crash in East Palestine, vinyl chloride, which is a monomer that comes from as one of the chemicals that's produced from petrochemicals, and going all the way across the country, you know, to be made into the polymer polyvinyl chloride, which is one of our major plastics. And then, of course, the enormous fire yesterday that's on the news right now. And the fact is that we don't have within our educational system training that prepares people in healthcare for even understanding those connections. I actually don't believe, Victor, that most people in healthcare realize that, you know, when they're venting off anesthetic gases, the extent to which, you know, if there are thousands of people around the country doing that at the same time, that's a lot. And it reminds me of when we took the fluorocarbons out of products to protect the ozone layer, that many people thought that was unreasonable. I just want to use my can of hairspray. What harm could I be doing? Well, with 80, you know, with all of the millions of people, billions of people we have on the planet that all might be using hairspray at the same time, that's actually a lot. But people don't think that way. They think in terms of what's my individual contribution. But so, Anne, you're an educator, you know, in many ways. What do we need to do as educators to be able to produce doctors, nurses, public health experts, others who are more literate about these determinants of health and the connection between these global changes and the health of their families, their communities, all the rest of that?
Yeah, I mean, I would start with some good
Yeah.
news, which are our climate change communication science colleagues, both at GW, at Yale, and elsewhere, have been tracking surveys of citizens in the US and now globally in multiple countries. And there is an increasing awareness amongst general citizens. Yes, climate change is happening. Yes, it's hurting me and people I love. You know, yes, we need to do something about it. So all of that is a good prepared ground in some regards. In the healthcare worker space, though, how are we incorporating this education in a holistic framing? And in that regard, you know, again, there are, I think, some levers we need to think about, which is if you make it part of the accreditation, if you make it part of the credentials, if you make it part of certification, that is often a motivator. So we now have some, you know, examples. Certainly I can speak to in the United States, the accrediting body for advanced practice nursing. They actually have made planetary health principles and content a part of the required core competencies for education. We now have a couple of studies out. One study recently by Shea and others surveying 84 different health science schools globally. About two-thirds of the schools are incorporating some content in this space about climate change, about an environmental perspective. Social determinants of health framing is often used now increasingly. Often that content is woven into some of the core coursework. And anyone who's been a faculty person or a student, you know that there is this problem with just trying to cram additional content into a very already overstressed curriculum. So again, how can we think about tools that can convey different styles of learning, different ways of delivering content, not just in the pre-service stage when we all learn to become a nurse, a midwife, a physician, a hospital administrator, a pharmacist, a social worker, but then across the life course of someone so that there's continuous learning. So looking at the continuous professional education models as well. At Yale, for example, we worked with the Alliance of Nurses for Healthy Environment and Healthcare Without Harm to create a continuing education course for nurses and midwives for the millions, 4 million practicing nurses in the United States, 19 million around the world who are already in practice. They didn't get this content in their pre-service education. How do we do that lifelong learning? And again, I come back to how might we consider doing using tools, information communication technology tools, because we know we have faculty shortages everywhere. That's the choke point for providing more health professionals. We know we have aging faculty. We're not always incorporating physical health with mental health care delivery, and our colleague, Dr. Atwali here can speak to that, hopefully in the Q&A section, as we think about the incredible need for mental health services around the world and interprofessional approach and community-oriented approach to delivering that. We need to think about paraprofessionals and team-based care. We learned a lot from HIV care delivery and team-based care and task sharing ways to deliver care. So we have some things to build upon, actually, and I think we really should be able to use those more often.
Thank you, Anne. Victor, you wanted to add a point.
No, I was, first of all, in response to, and certainly one of our work stream in the decarbonization or the grand challenge is to bring together all the educators, the credentialing agencies, et cetera, to look at how to create, what are the gaps in learning and how to create a more standardized curriculum for all health professions, and being able to be facile with the information, but also practicing, means of reducing carbon emission. But I was going to think, looking at this audience, global health interest, of course, all of you are public health and local health as well. I'm thinking, what are the kind of things that you should be doing? And I was thinking about the following. First of all, your voice, your leadership. It's really important that you speak up about this issue. And as John Balbus says, it really shouldn't be seen as something outside global health. It's part of global health. And in fact, since we have so much attention being paid to COVID-19 infectious disease outbreak, it's really time to recognize NCDs and climate and others are still there and it's getting worse. So really important for you to get involved with this. Secondly, I think the global health leadership should be a lot more vocal in this area. And we're not hearing this, right, John? Not enough. And, so when you think about this, aside from the big voices in leadership, the amount of global health financing, although we'd like to see more, is not small. And so Global Fund, Gavi, I can go on and tell you about them. They have tremendous buying power. So if they were coming together to say, you know what, we need procurement standards from supply chain, that'll be a big area to move forward, right? So John, that's our COP28 ideal, right?
I'd love to just comment on that, yes.
All right, but I'm just saying that there's a lot more you can do. Now, in the communication arena, I think all of us can bring the message, because even though Anne says awareness is high in climate change, awareness of climate change and human health is low, and there's a sense of urgency. So I think not only do we need more data to link climate change to human health and equity, but we also need a lot of storytelling narratives, and particularly in communities that's greatly affected, where they can really tell people about what's going on. A linkage between narrative and data is a very powerful way of going forward. And of course, we need to understand the language and speak the language of the decision makers. What do they think about, right? Every day, think about, okay, what's my politics, what's my budget? But being able to talk about to them, whereby they can recognize what we do is going to only be helpful to them, but helpful to everybody else, connect to priorities. I don't think, as I think it was maybe John and Anne who says, we don't tell enough, or maybe it was you, good stories. We need to tell some success stories too, because every story we tell is gloom and doom, but there are really successes that we can tell people, well, when it's done right, look at what's going on. So these are some of my thoughts about what this audience can really help to do.
Well, I thank you for that, Victor, because I agree. We do need the positive examples. And I think that the collaborative that you've put together will help to generate some of that as things come along. But I did want to return to an issue that that John raised and maybe ask John about it first. And that is, you talked about how your office is working on plastic as well as on climate. And these things are intertwined as issues. And when I'm thinking particularly about the healthcare sector, I mean, just how much of what is done, especially in the US and hospitals, involves disposables that are either plastic or some other material that is not recyclable. It is not a circular economy at all. It all goes into waste disposal at some point in time, incinerated, hopefully in a cleaner incinerator, but really is that what we want, right? What are we doing? We're creating CO2, we're burning something, right? So we don't want to burn things. And it certainly is not capturing that carbon in any way that's useful, even. I mean, even if you were just taking that oil that came out of the ground and putting it into that disposable stuff, no, it's not, because eventually it's going to be burned and it's going to wind up in the atmosphere. And so, how do we change that in healthcare? I mean, it does seem like it might be harder to directly connect all of that to the actual, carbon emissions. There's so many other emissions you could measure, but it does seem, particularly problematic in our context in the United States, perhaps in other developed countries, just how much disposable stuff. I mean, and you see them open up a pack, by the way, and use 3 things out of the pack, and the rest of it is thrown away, right? That's what they do.
So last week I was watching a movie called Exodus. It's from 1961, I think. And there's a great scene there where a nurse has to save the life of Paul Newman. And she takes out a syringe. Her hands are good. She doesn't drop it because it was glass. It would have shattered. And she takes out a metal needle. She screws it on. And I was just sitting there thinking, man, there's no plastic in 61. That was before 1969 in the movie The Graduate, right? We get a lot of calls and emails. There is an industry out there that's working on this. It's not a small issue. And it's an issue that has to be based on evidence and life cycle analysis and an absolute demonstration of adequate safety. Because if we start taking steps that reduce the safety of patients, the movement to sustainability will stop dead in its tracks. I think it can be done. And I think that there are companies doing this. This week, there is also going to be a rule coming out from the EPA on ethylene oxide. So, as we, start going to reuse and sterilization, we have to make sure we're not harming the health of nurses and other healthcare workers from those emissions. It's not easy stuff.
Also, the communities that are close to the ETO
and the communities
plants
that are near the big industrial ETO plants. Exactly. But
John, you would agree it's a big industry, and that's one reason why there's so much waste, right?
Yeah.
And the evidence is still not there, in my opinion.
But we're moving along that. And Victor, I think it comes back to what you were saying about the procurement standards. And I just want to say, a word about this. The National Health Service England is out in front of all the rest of the world in determining what are the steps that are reasonable and putting them into requirements. And this is one of the ways in which our office is acting as well. The US and the Biden administration are working on the contracting requirements for the entire federal government. And the federal government includes the Department of Defense hospitals, the Veterans Administration hospitals, the Bureau of Prisons hospitals, Indian Health Service, et cetera. So all the health systems of the federal government will have to comply with these new contracting requirements for reporting of greenhouse gases and reduction of greenhouse gases. The Action Collaborative is working in a public-private partnership. We are sitting down with the National Health Service of England to produce a guide, starting with our 2 countries, for how all these global pharma companies, all the global manufacturing companies can meet the standards of both the US and England. And hopefully This is one of the things we hope to bring to COP28, one of the things we hope Attach will take up, and this becomes something that creates that glide path for industry to start reducing their greenhouse gas emissions.
I hope you're also involving the FDA, because the medical device companies, many of them are very small and they're not global, and they don't build into the design the ability to sterilize in a way that is better for the environment. That's not even a consideration in the past an FDA review, right? John?
Yeah,
If I could, we're absolutely working with the FDA. We hear from FDAs, we hear from CMS that their authorization under Congress does not include their ability to regulate environmental issues.
That's what they say.
The FDA says that, and CMS as well. So there is a congressional aspect to this as well.
So Lynn, but on the FDA side, there's also the good side. And then I also hear from company supply chains that any change they make to a composition needs to go through regulatory process that really stifles innovation when you want to change packaging, change things like that. So that too need to change, right?
Yes,
Yeah.
absolutely.
So we have some time now for questions from the audience. And I believe, is there a mic that can be passed around? Yes, could you come to the front? And I think the first hand up was right in the front row here. Person in a white
All the
shirt.
way from
This one.
Edinburgh.
Thank you. All the way from Edinburgh. Liz Grant from the University of Edinburgh. And we talked about mitigation, we talked about adaptation, there's not enough funding at all, resilience strategies. But there's a fourth strategy we're not talking about, which is alignment. Though you've referenced it, do we need to very proactively focus on alignment for co-benefits? And can the health sector actually model that alignment and show how for every other sector, if we purposely invest in alignment, we would see something different?
Would you mind defining alignment?
Yeah, what do you mean by alignment?
Alignment. So I think it's my accent. So for all of the different sectors, we're putting in quite a lot of money around mitigating strategies for energy, for built environment, for food and ag. But we're not saying to those strategies, you have to align your interventions and your investments so that they have a health metric, a health co-benefit.
Yeah.
If we did that, is there a possibility you could create quite a big leap? Because alignment won't happen just by...
Yeah.
Sure.
Liz, can I address that? I think John Pat's there. We have an initiative called the Roadmap I mentioned earlier that has Andy Haynes and Julie Roden, but John's part of that planning group, as was others, to look at exactly that issue. Because as I said earlier, you're looking at many different sectors that all contribute to climate and health impacts. And alignment is what we call systems thinking, right? John, you want to say a word about that?
Very quickly, yes, that if we can think about across sectors, how there's a health benefit to decarbonizing, and there's this, it would be transformative change across all sectors that have some health and equity criteria in each of the decisions. And I'll just quickly say that Don Berwick, in the decarbonizing the healthcare sector, one of his first comments was, we need less demand for healthcare, and that means prevention first, and prevention is cross-sectoral.
Thank you for that, John.
Could I?
There's a woman in the back.
Could I answer that too?
Okay, but take the mic to the back, a woman in white, and we can have the panel continue to respond, but that'll be our next question. Go ahead,
So just a couple
Wolfie.
answers. So we
And
have
John.
a fourfold mission, and one of those four is alignment. One of those four is to work on harnessing the power of climate investment to address underlying health disparities. And it's not even a climate change issue, right? So there's hundreds of billions of dollars through the Inflation Reduction Act going out to communities to do everything from tree cover to bioswales to reflective surfaces, et cetera. And your question is, can we put into the multi-criteria decision-making around that optimization of health benefits? It's a really, really simple question. It is one of the hardest things to get done in the real world. And I'll tell you some of the reasons why. I mean, in the United States, all of this comes under something called the National Environmental Protection Act. Every major act of the US government has to have a health impact, has an environmental impact assessment, and theoretically the health benefits are there. But it's hard to do. There's not a lot of expertise, and it slows it down. Now, the reality is that when hundreds of billions of dollars have to go out the door, they often don't get 3 years to think about it. And, you know, Congress gave us the budget in December this year. That was a blessing. It wasn't March. So in the 9 months of this year, hundreds of billions of dollars have to go out into those grants. Hundreds of decisions have to be made. So we have to find a way to change the, you know, it's a really big challenge. And I'll say that there are many things going on right now. It would take too long to describe them, but there is an effort to do this. The decision-making for the IRA is based on a tool that does have, you know, the climate justice environmental screening tool, as you know, so it's being done through a lens of social justice and environmental justice. It should be in there. The guidance on how to do it well, not quite developed yet. The commitment to it, the understanding and the commitment to it, not quite there yet. It's things like the roadmap, things like, you know, we just have to keep that drumbeat going.
I mean, I've seen, John, hundreds of those NEPA reports, and they take not only a long time to make, they're made by consultants, they make a lot of money doing it, and they tend to be very generic at the end of the day. And screening tools and other tools, that is such a brilliant idea. I hope that can happen. Kofi.
So I do want to shift the gears slightly to how does this impact in the global context? I mean, you know, a lot of this discussion has been much more domestic. But I completely concur that one of the important steps that we need is really alignment between agencies, and particularly around speaking the language that would work towards both a synergized push and pull mechanism. And I'll give you one example. Over the last 1 year in particular, maybe a little longer, the IMF has been engaged in my own country, Pakistan, in just negotiating a simple IMF agreement for a small amount of money, a relatively small amount of money, but pretty important in terms of the national economy. They put on the table 68 conditions that the government of Pakistan needed to fulfill to make that agreement. And not one of those had anything to do with substantive health, leave alone climate change and health, on mitigation strategies, adaptation strategies. So I think until the time that we have these global agencies work together on a consistent message and platform with the money behind it, like the World Bank, I don't think we're going to make much progress. And it's therefore got to go beyond WHO sitting on the table only to WHO being central to some of these discussions around what needs to happen for climate change and health.
Thank you. I'm going to go to the
Hello.
next question in the audience. And if you
Hello,
don't mind
ma'am.
standing up when you ask, so we can, and say who you are.
Please, I'm Ruhia Baba Isa from Ghana. Please, I would have loved for us to improve on preventive. Gone are the days when we used to have preventive. Unlike my country like this, they used to say, wash your hands, do before you do everything. So unlike nowadays, because of lack of education, people, because of lack of education, at the background of preventive, the people are lacking knowledge about this preventive healthcare, measures of healthcare. So I would have loved for the world, I would have loved for the I would have loved to No, I would have loved for them to improve on preventive.
Okay, I
measures.
think I think I have the question, which is the lack of education around prevention for healthcare workers, and the need to improve that. And then whoever's doing the mic, if you the next question will be this fellow in the third row on the end, but I'm going to give this to the panel to address, along with any other issues that you feel.
You know, I'll just touch on a piece of what I think I'm hearing, which is, you know, how do we embed better protection of people from climate change risks in just the essential kind of communication we have as clinical providers and public health providers? Is that part of this?
Mm-hmm.
So one of the things that we're trying to do, because we know, you know, healthcare providers, they have to worry about hand washing, they have to worry about COVID, they have to worry about sexually transmitted diseases, guns in the home. There's so many things they have to worry about. And again, environment tends to be not included because it's not in the training. It's harder. It seems like somebody else's thing. We're trying to create ways to embed indicators, data-based indicators of climate-related risks from heat, from flooding, from wildfire smoke into the systems, the electronic health records, so that it becomes a prompt. You know, you should be checking to see if this person has an air filter, and if, you know, and we're working with Medicaid to get waivers, so Medicaid pays for the air filter to prevent, rather than Medicaid paying for the inhaler to treat. So that's one way that we're trying to do this, is just to try to bring this into the automaticity that is growing within healthcare delivery in so many places, and put these kind of data sets that we're creating to help providers understand who's at risk for different kinds of climate-related diseases and impacts.
I should say, John, I can remember when I trained that it was hard to get reimbursement to help people quit smoking, and that changed. And so, I mean, it is possible to change these things that healthcare providers can be involved with, but it takes a lot of effort. The whole value-based care model. Our next, oh, go ahead.
That's one of the things that, in fact, Collaborate is trying to do with West Fowler, how to actually do value-based care, you know, related to climate change environment.
Thank you. Next question.
Thank you very much. Hi, Nick Bass from London. I really like the idea that you've brought social determinants of health into this really important argument. I just want to mention that there seems to be a paradox at the heart of all this. Poverty, countries that are poor aim to deal with this, and by growing themselves out of poverty. And we know from, say, Hans Rosling and Gapminder and people that you know, one of the single biggest correlates of better health is better wealth. And the way a number of these poor countries, who are the most vulnerable, who are the lowest emitters, are actually going to go about this, is to actually take an extractive approach to mining and to drilling their natural resources. Uganda, DRC, and in a different way, Brazil, for instance, last year Bolsonaro was happily burning down the Amazon rainforest because he said it belongs to us, we can do what we want with it. And the idea was to clear the ground so that you can have more cattle to turn into beef, which I'm sorry to say, a lot of which get consumed over here. But DRC's argument about this and about destroying rainforests and opening this up to all the oil companies, etc., was that really, the state of the world was not their business. Making their country richer was. So on the one hand, you've got this this rapid, obvious opportunity for poor countries to grow to become middle-income countries, and thereby improve the health of their populations, against the fact that we know that ultimately doing this in the longer term will be damaging to health. What is the solution? And you've got to deal with this.
Thank you. I'm going to turn to the panel, but the person immediately behind you, you can hand the mic to him. He set his hand up. And who wants to start with that question? Kofi?
Well, it's a big question, and it's a question that has to be addressed through the lens of who takes the decisions in those countries. Many a times, particularly relating to extraction and what happens with the mining industry is people hardly have a voice. The decisions are generally taken in those industry by politicians, people who have clustered power, and hardly ever by communities themselves who may have a different opinion. So Bolsonaro is a great example. People who threw Bolsonaro out eventually were the very people of Brazil. They were fortunate because they had the ability to. In many other places, people don't. So I think the answer is greater empowerment at the national level for their own developmental planning. And within that developmental planning is also to look at what are the long-term trajectories for health, growth, and development. And Hans was correct, he was a friend of mine, and what he said was health and wealth of nations are intertwined. But the only pathway to improving wealth is not through investments in infrastructure, industry, mining. Health is a great pathway to wealth itself. There's not a single country in the world that's climbed the development ladder with an unhealthy, malnourished population. So I think the health and wealth of nations are intertwined in terms of domestic policies that are based on evidence, that are based on egalitarianism, that are based on the principles of justice, equity, and on reducing the disparities between the haves and have-nots. And that has also happened in Brazil in good times.
And
Yeah, there are, of course, these structural factors, and extractive capitalism is a force, no question. And of course, the irony with many of the renewables is the rare metals problem, right? That said, there are some examples, even this idea of local empowerment. There's a nonprofit called Health in Harmony that has been working in Indonesia with rainforest communities for over a decade, radical listening to hear what the communities wanted, which was give us alternatives to cutting down the trees, chainsaw buyback, and delivered healthcare, nurses and midwives, reduced child mortality, improved maternal health outcomes, and resulted in a big drop in illegal logging and in carbon sequestration, increase in carbon sequestration. So, there are some local empowerment examples where when you combine the health with the wealth, but at large scale, there are challenges as well.
so there's a person in a white jacket in the back. If you could take the mic and bring it to her for the next question. Oh, but I guess you haven't asked your question yet. That's true. Sorry about that.
So, Quentin Knight from Vanderbilt University and CUGH, but I have a question. The question about education, I think, is really important, and it's a little worrisome to me that we're still doing it in a very haphazard way. If we can slip it into the curriculum, maybe we'll. And I think Dr. Zhao and many of you were even on the Lancet Early Commission on being more deliberate of healthcare education for health professionals. I wonder if you can elaborate a little bit more on how it can be much more deliberate about that, and if there are examples of where it's being well done. But probably even a little bit outside of that, another form of alignment is aligning education right across the disciplines. I mean, to what extent are we in law schools, engineering schools? There needs to be aligned. Politicians need to know that these are the people coming out of universities, the next generation who could really influence policy. So that's another kind of alignment. Education is key in all of this, besides public education. But I think we need to focus very much on universities.
I'm sure Anne has lots of good ideas, but let me just quickly talk about the way I see it. There's no question that our health profession, particularly medical education, needs to be reformed. We still live on the Flexer report and many others, where now so many things have changed. To make a long story short, I wrote 2 papers in Lancet to say how we need to change things, particularly when we're missing the last mile, if you will, of the education, which is really understanding society, human needs, and others. And we do a lot in the discovery, translation, and things like that, right? So my feeling is that one should take a look at how much is needed in take medical education, 4 years in terms of what to learn. I would argue that the medical education today in the 4 years taught in 3, because there's a lot of wasted time, right? In the 4th year, they go to a internship, they're going around, there's no more pressure. And so I think we can really make some serious changes. But the important issue, my feeling is educating a group that looks at societal needs they're community sensitive and communication, what's the word? Good at this, right? To be able to understand what the issues are in community. And hopefully with AI, that a lot of the basic knowledge and acquisition can be done through really good digital technology, et cetera. So I believe that the stars are somewhat aligned now with the change in digital data technology to free up more time for people to have more to understand community needs and cultural needs and many other issues. I think that needs to be changed.
John, oh, I'm sorry.
Well, I just get, we need new models. You know, the system
Thank
of clinical
you so
education
much.
has been broken prior to COVID. And of course, COVID made us pivot,
Fine.
and in many
That's right.
places, people had to flip entirely into online and virtual education, including for clinical simulation and other things that we would have said before. I know it must only be hands-on. So I think we do have to think about using these tools. Some of what you're talking about, Quentin, it's science literacy. And that starts, you know, in kindergarten, you know, through primary school, through secondary school, which New Zealand has embedded climate change principles into their elementary school and primary school system, for example. So there are examples taking it even further before university, because what proportion of every population in every country is able to go to university?
John.
Two quick things. I'm very skeptical of a top-down approach. I think change will come from two things. One, it's already happening bottom up. It's going to be the next generation of students where I see real change in medical schools is not being driven by people with my hair color. It's being driven by the students themselves. The second thing, somebody who's worked on this for 30 years, it's not going to change until the regulations change. When every single healthcare facility has to report on its greenhouse gases, every single health professional will understand what a greenhouse gas is and not before.
Good point, John. I mean, I would add a point to this one, because I do think that, you know, when we educate, we are communicating knowledge and competencies. And I think that medical education has been too towards knowledge. And the knowledge is a very fluid thing. It changes all the time. And if I were to base what I do today on what I learned in medical school years ago, that would be ridiculous, because a lot of it isn't even true anymore, right? And that we should be focused on competencies, on lifetime learning, and on competencies that are broader, that, you know, are not just about being able to understand genetics and meet genetic data, but to understand social determinants of health and understand environmental determinants of health. And because we aren't just our genes, you know, all of those things are important. And medical education has been very stuck, I think, in a past when you needed to have all that knowledge in your head in order to be able to make an evaluation, in order to be a good doctor or nurse or whatever. Yes, Kofi.
So Lynn, the only thing I would add is that in addition to competencies, I would add the element of capabilities, because I think the more you take this to low and middle income countries where you are dealing with community awareness and also a lot of opportunities for change, linking this to empowerment, to gender issues, to education, and importantly, to starting early. I think, John, you said why the next generation is so important. You have to ask yourself why our children are so much more aware of these issues. Our grandchildren are so much more aware of these issues of climate change than any of us were ever or even are today around the nuances and things. And it's because they're starting early and because they are not dealing with the issues of fixed ideas and perceptions of years that are difficult to change. So I think starting early, and particularly pre-med school education, starting with our high schools and bringing those in, is what will change things in countries.
Partly, Kofi, I'll push back a little bit, because they are also at risk for learning things as we understand them today and not having the facility to be able to continue to learn over a lifetime. And which is, you know, because they see the world more clearly than we do. They're not burdened by the things that they learned 20 or 30 years ago because they're younger. But I do think you're right that there's a lot of hope, you know, in terms of their ability to perceive at least what
they're much better networked, and they have sources of information which, you know, is much less biased at times.
So there's a questioner in the back.
Yes.
You've had your hand up.
I
By the way.
have because hi everyone. My name is Sandra Trapa and I am also Ghanaian, but I'm a PhD student at the University of Alabama. So today we talked about climate change, pandemics, and its connection with social determinants of health. So my question, I want to be able to connect both factors and then perhaps you'll be able to answer that. So to make it easier, I'm going to make it like a case study, like a personal case study. So my mom is in a low to middle income country, Ghana, and she sells plastic for multiple years. And that's how she took care of me to go to school. That is her livelihood, you know? So in a situation like that, connecting social determinants of health, which includes income, how do we deal with that issue? What would I tell my mom?
Well, I might start with that to say, you know, your mom sells plastics. Well, she sells materials. She sells materials that people need, right? And right now that's plastics. And 50 years ago, it would have been something else. And 50 years hence, it's going to be something else, you know? But what she has is that she has a customer base. She has some kind of a supply chain. She's a good businesswoman. She knows how to make a living selling a material. Does that have to be plastic? No, it doesn't have to be that. That happens to be how, you know, the basis of our economy. And you know, I do believe that it's possible for people to forget that, you know, if we are to move away from plastic, that doesn't mean we don't need material. We still need material. We live in a world where we need some things. There are things we have that we probably don't need. I could point to some things like that, you know, that I've got in my house. I have too many things in it. I will confess to that. But we are going to need to have materials. So I think the issue is with these transitions, how do people take the skills and abilities that they have to adapt to change, which might be, you know, in 10 years, she's not selling plastic, but I can't tell you what she would be selling. John.
And I agree with you completely, Lynn. And, you know, she sells materials and other people sell energy, right? I mean, it's writ large. The wealth of this current society is based on fossil fuel. And so, you know, there has to be an intention, the transition has to be intentional. And this is something that's happening right now within the Biden administration. There's a very active group that's just looking at the coal communities alone, because this has been one of the huge sources of political opposition in this country to progress on climate change, has been that there are many, many communities, you know, in the Appalachian part of the country and the upper western part of the country that are dependent on coal. And if we were to stop using all that coal or stop exporting that coal, what would their mothers do? You know, what would their fathers do?
And I think that's a more difficult problem than selling plastic, because I think that, you know, you're dependent on a hole in the ground that's near where you live, where you go there and you work there and you're paid to do that.
Yeah.
So your community is based around that hole in the ground where that thing is produced. That's a more difficult transition than selling. I know that doesn't sound that way to you, but it actually is in selling plastic.
And it is. Yeah.
That is the only thing she knows. How do we make the situation better? If she's been doing it, it's almost like telling someone, I don't believe in climate change. I don't think there's any effect on climate change. What do you tell somebody? And when you're telling somebody like that, you have to consider their socioeconomic status. This is all she knows. What is she going to do? What am I going to do if I'm dependent?
So I guess I would push back and say, what are her customers going to be demanding if there's not plastic for what they need? And does she have a degree in chemical engineering? How did she learn to sell plastic?
Your point though is very human. It's about livelihood.
It's about livelihood.
It's about survival.
I think it's easier to think about this issue on a grand scale. However, the factors that contribute to the issues in climate change, it starts from individuals. It's individuals that make a group, and it's a group question that causes the effect on climate change. And so as an individual, I have my mom. How can my mom and I contribute to bettering the issues in climate change? That is my main question.
It's
So
the
not
empowerment
about,
issue.
like, materials, or it's just dealing with the social determinants of health, which includes income.
Mhm.
What can we do? Like in our generation, we talked about, we are more aware of it, but perhaps our parents are not.
Can I give her an answer which may
Yes.
be a little bit more relevant?
What am I telling my mom?
So I think your point is valid, and it's a very relevant point from a low income setting. I come from one such country. So 15 years ago, there were people selling tobacco products around the time where this was their main source of living. And transitioning and changing from a scenario where those people who were earning their daily bread from something that the government decided as part of the tobacco convention that they were going to go move away from was extremely challenging. I mean, how was that achieved? That was achieved through an incentivization program where people who were selling tobacco were encouraged and at times supported to go into alternative products and to wean them away from something which was clearly harmful was decided at a national level. Dare I say, in Ghana, just like in Kenya, Kenya banned the sale of plastics, and not only banned the sale of plastic bags, made it criminal to bring a single bag into their country, even if you were a tourist, with heavy fines. But they created the opportunity for people to move away from that to alternatives such as paper bags and things. So I think this is what I meant by capabilities and empowerment, that you have to empower communities, societies, and governments to be taking those decisions in solidarity with people to support them, rather than leave it to the individual who may or may not understand the nuances and consequences of some of those actions.
And I guess also to your point, can't actually do it on their own, without some kind of support around them. And I think that's what it really needs to come back to. So I see 3 hands, but not even 1 minute left in this session. Is that correct? Somebody was giving me yes. So I think it's time to close the session. I think the speakers may be willing to stick around for a couple of minutes if you want to come forward and chat a bit. But thanks to all of you. Thanks especially to those of you who brought forth a wonderful discussion, Reggie.
So much.